Hello, my name is Tony McKenzie, and I'm a clinical research fellow at the Institute for Family Health. Today, for my capstone, I will be exploring barriers to cervical cancer screening through patient vaginal self collection. Here's an outline for this presentation. In the background section, I will discuss the development of my fellowship research question and the subsequent sub analysis, which is the main focus of this presentation. Cervical cancer screening, or CCS, is critical for early detection of cervical cancer. Historically, it is collected by a clinician using a vaginal speculum. The United States Preventative Task Force recommends that all people with a cervix aged 21 to 65 complete screening every 3 to 5 years. However, screening in the U.S. have been declining since the year 2000, as shown by the CDC data. This decline is due to multiple factors, including disparities affecting Black individuals, low income populations, rural residents, and transgender or gender nonconforming people, who are often underscreened. Another barrier to screening is a patient's reluctance to a provider collected exam with a speculum. A possible response to these barriers is patient vaginal self swab. In May 2024, the FDA approved patient self collection with a vaginal swab for cervical cancer screening. This will be done with a vaginal swab similar to the one shown here. Some studies have found that self collection has a potential to increase screening rates. However, some studies also report concerns of self collection accuracy among patients and providers. Using this information, I developed a hypothesis for my fellowship study. Does offering self collection influence attendance at cervical cancer screening appointments? During recruitment for this study, I noticed that some patients refuse self collection, prompting a sub analysis to understand their reasons. Here are the methods for my primary study, providing background for the sub-analysis. This randomized controlled trial is conducted at select clinics of the Institute for Family Health in New York State. Eligible participants are individuals with a cervix, age 30 to 65, who are overdue for cervical cancer screening. Participants are randomized into two groups. The intervention group offered self collection, and the control group offered provider collection. During recruitment calls, participants are offered the screening method based on their assigned group. If they agree to participate, the research coordinator schedules their screening appointment, and we measure attendance for each group. We noticed during recruitment calls that some participants in the intervention group expressed interest in cervical cancer screening but did not want to self collect. This observation led us to develop the sub analysis to explore their reasons. To develop the sub analysis, research coordinators recorded patients' spontaneous responses to self collection invitations. The notes were compiled to identify trends amongst those who declined. Themes were created based on these trends to understand common reasons for refusal. This ad hoc qualitative analysis emerged during recruitment for the primary study, using organic responses rather than structured interviews. Here are our patient demographics. We examined the responses of 14 individuals who refused self collection. Out of 72 potential participants, 10 agreed, 14 declined, and the rest did not respond to outreach. Most who refused were under 39 years old and identified as non Hispanic, Black, cisgender women. Here's a table of the themes that were uncovered. Discomfort with self collection. Participants felt uncomfortable with the possibility of collecting their own tests. Decreased self efficacy. Participants expressed concerns with collecting the test accurately. Preference for provider expertise. Participants linked a lack of self efficacy with a preference for clinician testing. 6 participants said that they would want a provider to collect the tests. 4 stated that they do not feel confident in collecting the sample correctly. One told us that she tried self collection in the past, but did not think that she did it well. Here are some quotes from patients who expressed the theme of decreased self efficacy. One said, "That sounds a little too hard," and another said, "I would not be good at it." A couple patients who expressed the theme of preference for provider expertise said, "I would rather a professional do it." And another said, "I would like to participate, but would rather go in for testing than do it on my own. One patient who expressed discomfort with self collection to the research coordinator said, I don't get why that self collection is an option. Our sub-analysis uncovered key findings. People are hesitant to collect their own cervical cancer screening because of discomfort, self-efficacy concerns, and preference for clinician-administered exams. These findings are similar to those of other studies where participants expressed concern for test accuracy. The findings of this study have implications for clinical practice and public health. One key implication is a need for comprehensive patient education on self collection methods, ensuring patients can collect samples comfortably, safely, and accurately. Additionally, provider education is essential to equip professionals with the skills to advise patients on effective self collection techniques. This analysis also highlights the importance of a hybrid approach to cervical cancer screening, offering both self collection and provider administered options to increase screening rates. Developing patient support and feedback systems is crucial to enhance the self collection process. These systems should gather feedback from patients and providers to improve self collection methods and create educational materials such as pamphlets, infographics, and videos. Further research should explore the reluctance towards self collection through focus groups, in depth interviews, and demographic trend analysis. Understanding these factors will help develop educational tools and guidelines to improve cervical cancer screening rates across the United States. This study had several limitations. The small sample size and ad hoc analysis, where data was explored as it emerged, posed challenges. Research coordinators did not use predefined interview questions, leading to subjective interpretations of participant responses. This subjectivity may have impacted theme development. Additionally, a general reluctance to participate in research, noted in previous studies, might have influenced participants' decisions to decline self collection, not due to lack of interest, but because they did not want to engage in a research study. To conclude, self collection has the potential to improve cervical cancer screening rates. Understanding patient hesitancy is essential to addressing this. Future efforts must focus on education and accessibility for both patients and providers. Here are my references. Thank you all for listening to this presentation.